All right, so let's, so the next few hours, we're going to go through just a very, very sort of overview of dermoscopy, but enough to get you going if you're not yet doing dermoscopy. And why learn dermoscopy? So this is sort of one meta-analysis, and I'm going to actually come down here and kind of move across. So one meta-analysis that was done that shows that there's an increased sensitivity and specificity for diagnosis above and beyond what your naked eye diagnostic accuracy is. So it's basically looking at the area under the curve that tells you that is your diagnostic accuracy. The dotted line is your naked eye, and the solid line is that when you add dermoscopy to it. This has been known for quite a long time, but there were many skeptics that continuously said, well, you know, my eyes are just as good. I don't really need to have any other instruments beyond my eyes to make a correct diagnosis. And there's a whole host of reasons why that statement is actually incorrect. But now, at least, I can give this as the only proof and not say anything more. And that is, for most of you here are aware of the Cochrane Library. The Cochrane Library is a group in England that basically takes a question, analyzes the world's literature on that, and then brings out a evidence-based review and opinion about different things in medicine and the different things we do. And many of us actually use that as our anchor for what we do. So, you know, should we do X, Y, or Z? Well, if there's evidence-based medicine for that, then we will lean towards that, and the Cochrane Library is the one that provides this evidence-based kind of reviews. So what they undertook was a very large review of close to 500 or 600 pages that actually looked at this issue. And the first one that they looked at is visual inspection for the diagnosis of cutaneous melanoma adequate? So just your eyes alone. And the conclusion was that visual inspection is a fundamental component of assessment of suspicious skin lesions. However, the evidence suggests that melanoma will be missed if visual inspection is used alone. So for those people who say that my eyes are just as good, here is a review that has shown that, sorry, your eyes, our eyes, are actually not as good. They went one step further, and that is they also looked at dermoscopy. And despite not having sort of large randomized trials and so forth, so on, based on the accumulated data that's present in the literature, they have concluded that dermoscopy is a valuable tool that adds to your naked eye examination. And so here now is finally evidence-based medicine that answers the question that, one, your eyes are not just as good, and two, is dermoscopy is an added value in the diagnosis of cutaneous melanoma. Really what's happening, right, it's sort of this idea of abductive reasoning. You see, we have incomplete knowledge about a given lesion. Is this a melanoma or not? And we use whatever pieces of information that we can gather to try and get to what the lesion is. If I see a lesion from the doorway, you know, and it's a large lesion, I don't know if that's a large seborrheic keratosis or if it's a melanoma. So I'm going to come closer. If I still can't figure it out, I will touch the lesion. I may take out a magnifying glass. I may do side lighting. It's all sort of this added information that's providing me with data that will eventually lead to me to know what this lesion is, or at least what I should do with this lesion. Dermoscopy is the same thing. It fits into this wheel, and with this added information makes you better in your diagnostic accuracy. And in essence, if you think about it, what's happening in milliseconds in your brain is that you have a hypothesis of what it is. I'm looking at it, you know, I think it's either a basal cell or an intradermal nevus. Say you have your differential. And most of us, by the way, when it comes to cutaneous malignancies, our differential is not 10 things. It's usually maybe 2, dysplastic nevus melanoma, intradermal nevus basal. I mean, it's not, you know, there's sort of this very small pool of lesions that's in the differential. So basically, you test your hypothesis. And that testing can occur with all the things we mentioned, but then in addition is dermoscopy. And if you have concordance, you have basically confirmed your diagnosis, and you manage accordingly. And if there is not concordance, you go back and make that loop again, so that everything has to fit to know exactly what it is. And you will see that over the course of these 2 hours of how that actually works. And this is sort of this example. So we know that if you look at the overall gestalt pattern here, you'll say kind of similar, okay? But the structures that make up the pattern under dermoscopy between the two is different. And a very, very important piece of the puzzle is that they also feel very different. So the one on the left is not firm, and the one on the right is firm and dimples. So you have added information, and then based on the structures that you see, you will be able to tell that the lesion on the right is a dermatofibroma and the lesion on the left is a melanoma. And we'll talk about the melanoma structures as we go along. But it's sort of, again, just to give you the idea of how do we actually end up making a diagnosis. Now, on top of that, when it comes to dermoscopy, there's also 2 ways that one can look at or evaluate dermoscopy images. One is sort of the analytical side of the spectrum, and the other one is the non-analytical side of the spectrum. The analytical side requires a lot more time. It's more time-consuming, and the non-analytical is a little bit faster. And it's important to be able to appreciate what's the difference between these two. So the analytical makes no assumptions as to what it is. You cannot say it's either a dysplastic nevus or a melanoma. You can't. You have no idea. And as a clinician, it's just not reality, at least for me, right? But you cannot make any assumptions as to what this animal is. It's not permitted. And then you piece together, well, I see these big feet, I see these white things coming out of this area by the head, there are these 2 beady eyes, there's the big ears, and then you put all those pieces together to create a picture. In the analytical world, when it comes to dermoscopic structure, these are the only structures that are present. So you have lines, pseudopods, circle, clods or globules, and dots. That's it. And it's the arrangement of these structures that then eventually leads to a diagnosis. However, that is very cumbersome. Taking each piece and when and where it's located and what is it associated with till you piece it together to get to the final answer, oh, it's an elephant, okay? The non-analytical is a little different, and I do think that most clinicians actually act on the non-analytical side of things. And that is, you know, I think this is an elephant, okay? I think it's a basal cell, all right, whatever. And now I'm going to say, yeah, you know, it is an elephant because I see these different features, right? So I can describe why it's an elephant. And similarly, I think it's a basal cell. Let me tell you why it's a basal cell based on what I'm seeing. And so in this fashion, you may have a differential, basal intradermal nevus, and then based on that, you can use dermoscopy to actually tease those 2 apart, or nevus versus melanoma. You can tease those 2 apart. And so this is how the 2-step dermoscopy algorithm is kind of structured. And so you have the cards, the laminated cards that go through the 2-step algorithm. For those of you who don't have those laminated cards, there's a bunch of them by the water station in the back, so you can get those. There's also a second card, which is the Tada algorithm, and we'll talk about the Tada algorithm at the end of the second part of this lecture. Okay, so now, what is the 2-step algorithm? So basically, it's going through your differential in sort of an organized fashion. And it's important to also highlight that the structures that you see have to all be consistent with the diagnosis you're making. What do I mean by that? So if you think it's a basal cell carcinoma, all the features on line 3 that are basal cell carcinoma, all those features are the only features permitted, right? If all of a sudden, in addition to that, you're seeing gyri and celsi and comedo-like openings, and they don't fit together. So the specific diagnosis that you are making, the structures that are present have to be only those structures that have been defined for the lesion, yeah? Okay, so what is step 1? So a very common lesion, sort of run-of-the-mill benign nevi, okay? Now, it's important to highlight that when I say run-of-the-mill benign nevi, this is a very big switch from 10, 15, 20 years ago. You see, most of the lesions on line 1, if you biopsy them, are actually dysplastic nevi. They are mild to moderate dysplastic nevi, but they are benign, okay? And so they now, it's sort of this idea of a beacon in darkness, that all of these lesions that we didn't really know how to classify, we now know that there is this one group of melanocytic neoplasms that we can confidently say that they are benign, okay? And that's in line 1. So what are those benign nevi? It's the network nevus, the patchy network nevus, peripheral network with central hypopigmentation, peripheral network with central hyperpigmentation, then peripheral network with central globules, then the globular pattern, whether it's round to oval globules or cobblestone globules. Then you have a network pattern with globules at the periphery, homogeneous blue, and homogeneous brown. Those are your benign nevus patterns, right? The silhouette of the lesion does not matter. They can be the most irregular silhouette, but as long as that's the only structure that you see and that's the only pattern you see, it's a benign lesion. We no longer do anything with those lesions. They're completely left alone. So, examples. So this is your diffuse network pattern nevus. Another example of a diffuse network pattern nevus. Then you have your patchy network pattern nevus. The patches of network are distributed in an organized and symmetric fashion throughout the lesion, and it's important. So organized distribution. Another example of the patchy network pattern. Notice that each island of the network has the same kind of network, the same color of the network, and again distributed in a relatively organized fashion. You have the peripheral network pattern with central hypopigmentation. Another example of the same, very common in fair-skinned individuals with type 1 and 2 skin. Then in type 3 and 4 skin, you start to get peripheral network with central hyperpigmentation, benign pattern, and another example of the same. Then you have your peripheral network pattern with central globules. This lesion, while it can be acquired, sometimes can also be present at birth, so overlapping, but even in the acquired ones, if you were to biopsy it, the biopsy report will come back as a nevus with congenital features, okay? So, and another example of the same, peripheral network central globules. Then you have the globular component, and the most common form that you see that is with sort of round to oval globules distributed throughout the lesion. But at times you can also have very large globules that create a pattern that looks like cobblestones. So here's sort of some cobblestoning in the middle. You have the round to oval globules at the periphery, and then here's a more blatant example of the cobblestone pattern. Again, this pattern is also, when if biopsied, will reveal features of a congenital nevus. Then you have another pattern, and it's important to acknowledge or to be aware that this pattern is defined by both criteria. The presence of network in the middle and peripheral globules at the periphery. Okay, so peripheral globules without a network in the middle would be a very different lesion, and we'll get to that later. But this specific pattern where you see network in the center with globules at the periphery is a benign growing nevus. So in individuals that have the atypical mole syndrome, for example, 50% of their new lesions that they develop will have this pattern, and they are undergoing growth, And from the time of inception to the time of senescence, where the lesion will have only a reticular pattern, takes about 5 years. Okay? And so this is an example. Network in the middle, peripheral globules, benign pattern. We don't do anything with these anymore. Leave them alone. We don't even monitor them. And then you have the homogeneous brown, which is another pattern seen in small congenital nevi, and the homogeneous blue pattern seen in blue nevi, with one caveat, and that is that in an individual that has had a history of melanoma, okay, an epidermotropic metastasis can resemble a blue nevus. Okay? So that's sort of the one caveat. A blue nevus, totally homogeneous blue, with that one exception of epidermotropic metastasis. But a primary melanoma will not have a homogeneous blue color. So that's your benign nevi. Okay, on the second tier, we define two lesions. Both of them are kind of raised lesions. One is dermatofibroma, and the other one is the intradermal nevus of either the Unna's type or the Miescher's type. And we'll go through the features of those as well. Now, dermatofibroma. This is actually, on the clinical level, an extremely easy diagnosis. Yeah? Firm, usually brown in color, and if you squeeze them, you get the dimple sign, so it's very easy. And then, if you just think about what the pathology of a dermatofibroma is, you will understand all the structures that you will see. There's increased melanin in the reedy ridges network. There is broadening of the reedy ridges, the ring-like globules. There is collagen stroma, the shiny white scar-like areas, or the shiny white lines seen with polarized light, because that's what's reflecting the collagen. And in the stroma, there's vessels. And so you can see the vascular blush or the blood vessels. That's it. Those are the only structures permitted in a dermatofibroma. So a symmetric lesion that's firm, that dimples, and those are the only structures that are permitted in the lesion that makes for dermatofibroma. So the most classic pattern is this one, where you have a peripheral network with central scar-like area. So the scar-like area is whiter than the surrounding skin. And as I mentioned, it's firm and it dimples. The network is due to the increased melanin in the reedy ridges. It's not because of proliferation of melanocytes. In the central area, if you look at it with polarized light, the collagen, instead of being shiny white, will appear as little white lines, also known as crystalline structures. And this can sometimes be confusing, because you will see in a little bit that crystalline structures are also a very strong predictor of cancer, right? So this is one of the exceptions to that rule. In dermatofibroma, they would be considered benign. These are the ring-like globules, which represent the widened reedy ridges, right, which are also known as the dirty feet of dermatofibroma on pathology. And then the vessels can also be seen in dermatofibroma, because, again, in the collagen stroma, lots of vessels on pathology are seen. These vessels are always within the area of white, right? So again, if you just think about the pathology, it all kind of makes sense. If these vessels all of a sudden are present outside on the network lines, it doesn't fit, yeah? The vessels are part of the stroma, so they should be within that white scar-like area, or within the shiny white line area of the lesion. So those are your features of dermatofibroma. You have network, you have the ring-like globules, you have shiny white scar, you can have lines. If you see the shiny white area will have lines on polarized light, and you can see vessels. Okay, what about intradermal nevi? So intradermal nevi, basically two types. The Unna's type, which is the fleshy ones, they're a little bit mammillated, a little bit sessile, soft. And then the Miescher's type, which are the classic dome-shaped ones, very commonly that you see on the face. Now, for the Unna's type, what are the features? Clinically, the features are sessile, mammillated, soft, pedunculated, right? So these are your the clinical features. What do you see on dermoscopy? So in terms of color, brown. So you'll often see brown color. The brown color can be distributed in globules, but also just present in skin, but not in a structure. So if you look at the middle image, notice that there's brown pigment, right? But it's not in a structure. It's not like in a part of a network or a globule. It's kind of just pigment that's present on the skin. And you'll see why that's important in a minute. And then sometimes they can be fairly hypopigmented, but there's nothing else there, just hypopigmentation. In terms of structures, really the globule is the main structure if present, right? You will see it as a round to oval structure. You can sometimes see it as a cobblestone globule, but globules of different shapes can be present in those lesions. And in some cases, you may also see Milia cysts and comedo-like openings. Now, the comedo-like openings are not true comedo-like openings. Basically, what they are is if you know this mammillated surface of an intradermal nevus, well, those invaginations of the mamilla, those invaginations, if they start to collect keratin, then you'll end up with these openings that can resemble comedos. They're not true comedos. They're just the mammillated surface with increased keratin. So you can have Milia cysts, and you can have these, let's say, pseudo-comedo-like openings within the lesion. Actually, Steve, is there a pointer, or Dave? Do you have a pointer that I can have? Now, vessels is another, is it on here? No, right? Oh, there's one on the podium. So vessels are very common in intradermal nevi, and thanks, great. And you can see here lots of vessels in the lesion. The key vessel that has been described as in intradermal nevi is this so-called comma vessel. They kind of have a little curve to them, kind of a shape of a little comma. And on this side as well, hopefully you'll see right here, kind of a little bit of a comma shape to them. But notice that besides having comma vessels, there are also other vessel shapes in here too, right? So, but it is in the realm of melanocytic neoplasms the only acceptable vessel pattern that you can have in a benign lesion. So, a sessile mammillated lesion with vessels, some of which have comma shapes, is a benign pattern. If you have any other vessel pattern as the predominant pattern, or you have comma vessels in a flat lesion, it becomes concerning. So the comma vessel is only considered benign in this specific morphologic, clinical morphologic type of nevus. Okay, why is that important? And I'll highlight that with these two cases. So notice you got two lesions very similar in color, and if you notice clinically, right, they're both sessile and they're both mammillated. So you say, okay, we got two intradermal nevi. Now let's prove that they are in fact intradermal nevi. Now, the one on the right, it has some comma vessels, and it has a mammillated surface, and it has these pseudo-comedo-like openings. But what about this lesion here on the left? If you notice, the lesion on the left does not have a predominance of comma vessels, nor does it have a true mammillated surface, as can be seen in the lesion here. And the central portion of it has really nothing. So it does not have the classic features of a intradermal nevus. So this is with the power of dermoscopy. Exactly the same appearing morphology on your clinical eye. On dermoscopy, that looks totally benign. That one looks, I don't know. So if you don't know, it comes off, and in this case, that's the melanoma, and that's the intradermal nevus. Purely based on the dermoscopic morphology of the distribution of the vessels and the type of vessel present, okay? Okay, now what about Miescher's nevi? These are these dome-shaped lesions. Most of the time, these are not a problem, right? But occasionally, they can resemble intradermal nevi. And to my surprise, when I ask patients, especially the anxious patients, well, how long have you had this? I'm expecting them to help me, right? By saying, that's been there forever, doc, it hasn't changed. But it's amazing how many times these patients will say, I have no idea, right? And so sometimes what I'll do is I'll have them go home and say, okay, why don't you pull out a picture from 10 years ago before we cut you or whatever. But these can sometimes be quite challenging. Now, why are they challenging to differentiate from basal cell, right? That's the main differential. Is the fact that they can sometimes have vessels that appear arborizing. They can sometimes have a rolled border as well. Okay, so I mean here, kind of a little bit rolled is a vessel there. Kind of very difficult to truly know whether this is an intradermal nevus or whether this could be a basal cell carcinoma. Now, this dilemma of trying to differentiate a basal cell carcinoma from an intradermal nevus is nothing new. Actually, in the late 1800s, there was a debate amongst the dermatologists how to differentiate the two. And it was during that debate that one of the observations that they made was that if hair was growing out of it, then you can be sure it's an intradermal nevus. That's where the myth of the hair sign to differentiate benign from malignant comes from, okay? It has nothing to do with melanocytic neoplasms. It had to do with the debate of differentiating basal cell carcinoma from intradermal nevi. Okay, now, dermoscopically, the features that you will see, often they will have arborizing vessels. But very often they will also have pigment that's not in a structure. In a basal cell carcinoma, in a pigmented basal cell carcinoma, the pigment will always be in a structure, meaning leaf-like, spoke wheel area, ovoid nest, blue-gray globule. It'll be a specific structure in which the pigment is residing. Whereas in intradermal nevi, the pigment will just be on the skin, not in a structure. That is one of the strongest features of Miescher's nevi. The other is that the vessels usually are not as bright red, often will have a little bit of a bluish hue, and will be a tad out of focus when, as compared to basal cell carcinomas. Now, I purposely put this image here because here this vessel is not blue. This vessel is clearly in focus and is quite red, right? But the clue here is the pigment that's not in a structure, right? That is an intradermal nevus. So again, the vessel pattern in the two can be very similar between basal and intradermal nevus, but the clues will be, if you're lucky, there'll be hair in an intradermal nevus. There's the pigmentation on skin, not in a structure. And on intradermal nevi, you will often have this kind of brown halo around the lesion. That's another clue of an intradermal nevus, whereas in a basal cell carcinoma, that brownish halo is not visible. And that was published in this article if you wanted to look at the brown halo feature. And it's pretty consistent across basal cells and Miescher's type intradermal nevi. Okay, now we move on to cancer. So it's not a nevus, okay, it's not a dermatofibroma. So now you kind of get into, I want to rule out my non-melanoma skin cancers before I start to think about seborrheic keratosis, because I don't want to miss basal or squame, right? I don't want to anchor my diagnosis on a benign before I rule out my malignant. So what are the features of basal cell carcinoma? These are the features. Blue-gray ovoid nest, blue-gray globules, and that's basically just defined by size, okay? So if a blue-gray structure encompasses more than 10% of the surface area of the lesion, it's considered an ovoid nest, and if it's less than that, it's considered a globule. You'll see histologically it's the same, yeah? So it's just an arbitrary differentiation. Then there are three structures, leaf-like, spoke wheel, and these concentric structures that actually all represent superficial basal cell carcinoma tumor-islands, and I'll show you that in a minute. Then you have arborizing vessels, ulceration, and when you look at basal cell carcinomas with polarized light, they will often have shiny white blotches and strands, and that can sometimes be the only feature to help you to know whether it's a basal cell. So let's go through those features. So, leaf-like structures. So you have a common base, and from that arise sort of fronds that create a pattern that looks like a leaf. In the analytical language, so the language that I'm using is obviously metaphoric, right? Leaf-like. In the analytical world, they are known as lines radial connecting to a common base. And you will see in a moment that the reason I prefer metaphors is, one, it's easier, leaf-like, instead of having to say all of this. And two is the metaphor allows me to have a little bit more inclusiveness as to what's within that leaf-like structure. So remember this, and I'll show you an image in a moment. So the classic leaf-like structure is this one here. So when we first observed this, we said, it kind of resembles a maple leaf. So in the old literature, it was called the maple leaf sign. But then we realized that it actually doesn't have to resemble a maple leaf. So here, for example, is a structure that's also leaf-like. It still has these prongs coming together at an off-center base, but now the metaphor of a ginkgo leaf holds more true than the analytical lines radial connecting to a common base. And that's what I mean, that the metaphors allows you a little bit more inclusivity than the analytical term. Now, what do they represent? These leaf-like structures represent basal cell tumor islands that are pigmented, but the ones that are up here, the ones that are coming off the dermo-epidermal junction, okay? It's not the ones down in the dermis. So, in fact, they represent the superficial component of basal cell carcinoma. Now, spoke wheels is kind of very similar to a leaf-like, and you will see how these all end up, we have arbitrarily made them into different structures, but in fact they all represent the same. So you have a common base, and instead of being just on, radiating from one side to an off-center base, all the radiations occur around the central base. Okay, so now instead of leaf-like, it becomes spoke wheel. And if each one of those radial spokes was not very distinct, you would end up with a structure that has been called a concentric globule. But all of these represent the same entity. They represent superficial pigmented basal cell tumor islands. And so schematically you can see sort of this overlap between leaf-like and spoke wheel and concentric structure. But let's go to some examples. So two superficial basal cell carcinomas. I will highlight the spoke wheel-like areas in these, then remove the spoke wheels. And so that's sort of been the classic spoke wheels. But let's look a little bit closer at this basal cell. And notice, well, is that really a spoke wheel, or is that kind of more leaf-like? That for sure is leaf-like. Maybe that's more spoke wheel. How about this, right? That. So you can start to appreciate that there's a little bit of play, all right? And here's another. This is that classic concentric globule, okay? So concentric globule. And then here's a basal cell carcinoma that reveals all three. So here's your spoke wheel areas, then you have your leaf-like area, and you have your concentric globule. And all three of these structures represent the same entity on histopathology, and that is superficial basal cell tumor islands, right? So they have tumor islands, pigmented basal cells coming off the dermo-epidermal junction. So if that's the only structure you see, you would be fairly confident that that's a superficial basal cell carcinoma. There are very few things in medicine, at least on the morphologic end for sure, that carry it with it 100% specificity. Okay, and leaf-like structures and spoke wheel-like areas carry with it 100% specificity. What that means is that if you see that structure, that's a basal cell carcinoma. We have not seen that structure in any other lesion other than basal cell carcinoma. It's one of the few things that has 100% specificity. Okay, now we get to the blue-gray globules and the blue-gray ovoid nests. And remember I said this was purely sort of size, but relative to the lesion. More than 10% of the surface area of that given lesion makes it an ovoid nest. And if it's smaller than that, it's a blue-gray globule. But again, you'll see that histologically they represent the same thing. So blue-grayish, smaller blue-grayish structures here. Those are the blue-grayish globules coming up, going down here in this lesion. You can have them much smaller. You can see them all in here. You can see them all in here. And it has the appearance of a buckshot scatter. So think of a buckshot, or those, that all the pellets are being shot out, and the pellets kind of going out in this random fashion. So the buckshot scatter of these tiny little grayish dots here is another variant of the same. So you have your blue-gray ovoid nest, blue-gray globules, and then you have these blue-grayish little dots as well. More examples of the same, and you can see the variation in structure, but notice that the distribution of them is again in this random, the way I describe it, buckshot scatter in basal cell carcinoma, another basal cell carcinoma, another one, same structures, and another basal cell with the same structures. So non-aggregated buckshot scatter, basal cell carcinoma. And when you see that, it really indicates that you have a nodular component. Yeah? So now we're going from superficial, we're going down to nodular basal cells. And then you have, when they become very large, you have the blue-gray ovoid nest. Again, it's all just relative. Once again, basal cell carcinoma of the nodular type, pigmented. And these are the structures that are the basal cell tumor islands that are present in the dermis. Okay, the fifth structure is arborizing vessels. So these are in focus, red, branching vessels. And here's the classic example of these arborizing vessels in a basal cell carcinoma. And in most basal cell carcinomas, right? Because most basal cell carcinomas are not pigmented. So in the non-pigmented variant, the most common structure to help you make the diagnosis of basal cell carcinoma is in fact these sharply in focus, bright red arborizing vessels. Ulceration, another common feature to help you with the diagnosis of basal cell carcinoma, and basically come in two variants. One is a clear-cut ulcer, as shown here. So you have, here's arborizing vessels, but you have ulceration making the diagnosis of basal. Here's another basal cell carcinoma. It has an ovoid nest, and it has arborizing vessels, and it has the ulcer. And then it can also appear, instead of an ulcer, it can appear as small erosions. So you have multiple small erosions as highlighted by this basal cell. Now, why make a distinction between an ulcer and erosion? An ulcer is a feature of a nodular basal cell carcinoma. Multiple erosions is a feature of superficial basal cell carcinoma. And you will see that becomes important in a moment. So it's to distinguish between a superficial and a nodular basal cell. And then the last part, the last structure, is shiny white blotches and strands that can only be seen with polarized light dermoscopy. And it carries with it also a very high specificity for the diagnosis of basal cell carcinoma. And they basically are shiny white blotches and sort of elongated white areas that we call strands. So here's a basal cell carcinoma that you're viewing with non-polarized light. The same basal cell carcinoma seen with polarized light. Go back and you'll see these shiny white blotches and kind of these strands. So when you see shiny white blotches and strands, it's also a feature of basal cell carcinoma, highlighted here as well. Now that previous basal cell was not so hard to diagnose because there's arborizing vessels, right? So it's easy. But where it becomes very powerful is in a group of lesions that we are now starting to diagnose in the hundreds in just my clinic alone. And so it brings into question whether this is a good thing or a bad thing, but we'll leave that for another discussion. But in the elderly, it's not uncommon to see these pinky whitish patches, yeah? You're not quite sure exactly what it is. But now with dermoscopy, that lesion is that on polarized light. So standard light, polarized light, shiny white blotches, and strands. Superficial basal cell carcinoma. Another example. Here there's some vessels, so it kind of, you kind of already know it's a basal, but the same lesion under polarized light, there are your shiny white blotches and strands. And this feature has helped us to diagnose many basal cells that we were previously ignoring. But almost all of them are superficial basal cell carcinomas. Okay? And the reason I made that comment before is that in the elderly, does it really matter that we are finding these? I'm not sure. Yeah? So now, we have gotten good enough with the correlations that we now know the features associated with superficial basal cell and with nodular. If you see arborizing vessels, ovoid structures, or ulceration, that speaks in favor of a nodular basal cell. If you see only these features, leaf-like structures, spoke wheel areas, vessels, but they're not arborizing, multiple small erosions, and shiny white blotches and strands, that speaks highly in favor of superficial basal cell carcinoma. And in fact, it has become so powerful that there are many places where if these are the features, or a subset of these features, and those are the only features present within a basal cell, that they will empirically treat those lesions. So maybe it's with a mycomod, for example, right? Without a biopsy. They'll just go straight to treatment based on the structures that are present. So again, being able to know what subtype, if you were to biopsy, will also help you to know how deep to biopsy. 2, if your intent at the time of the biopsy is to treat the lesion, you will also know how, where are you going in terms of the depth of treatment, whether it's with cryo or with ED&C, whatever it is, right? So it does help in terms of how you manage the lesion or how you approach the lesion, the basal cell, based on whether it's superficial or nodular. So those are the features of basal, all right? So on the pigmented side of things, you have ovoid nest, the blue-gray globules, the spoke wheel concentric structure, the leaf-like structures. In addition to that, things seen in the non-pigmented variant and the pigmented variant can be arborizing vessels, ulceration, multiple erosions, and shiny white blotches and strands, okay? Those are the only structures associated with basal cell carcinoma. Okay, what about squamous cell carcinoma? So one of the key features of squamous cell carcinoma from the get-go is that it's a scaly lesion. So on the clinical examination, right, there is going to be texture to the lesion when you run your hand across it. In addition to that, the features of squamous cell carcinoma are listed here: glomerular vessels, white circles, rosettes, brown dots lined in a linear fashion, strawberry pattern, and I'll talk about that in a minute. And in some cases, you can see hairpin vessels with a white halo. That's it. There are no other features that one will see in squamous cell carcinoma, both in the pigmented variant and the non-pigmented variant. Now, obviously, we heard some of this morning, right? There is a continuum from an actinic keratosis to a squamous cell carcinoma. Actinic keratosis being defined as atypia that does not encompass the entire thickness of the epidermis, whereas once it does, it becomes squamous cell carcinoma in situ. So yes, there's going to be some overlap, but there are a few things that we do know, and that's worth mentioning, that there are patterns where we are fairly comfortable knowing that that's an actinic keratosis and can be treated as such without fear of treating a squamous cell carcinoma, a bona fide squamous cell carcinoma with full thickness atypia with, say, liquid nitrogen or some other destructive modality. And that's for grade 1 and 2 actinic keratoses. So people have looked at what are the dermoscopic features in the different grades of actinic keratosis. The most common feature of actinic keratosis in grade 1 is this red reticulated pattern, okay? And sort of like a pseudo-networky pattern, but kind of all this red lacy pattern. And that's the only thing you will see. In addition, if you run your hand across it, it will have a rough texture, okay? Those are not squamous cells, bona fide squamous cell, full thickness atypia. These are the not full thickness atypia, AK. In addition, those red areas, you can on occasion see these linear vessels within it, and these white structures that you see, these white structures, these are osteal openings, and they're filled with keratin, so they become bright white. So bright white with red around, actinic keratosis, okay? Now, as you start to get into high grade 2 and 3 actinic keratosis, now you start to get features that are overlapping with full-blown, full-thickness atypia squamous cell, right? But on biopsy, these are not full thickness. And that is, you can start to get lots of white structures filling up the osteal openings, also known as white circles, okay? You'll start to see lots of these rosettes, these little bright 4 points of light, and lots of keratin. In addition, you can now start to see vessels in the form of little glomerular vessels. And at this point, once you see these glomerular vessels and these white circles, right, you actually don't know whether that's squamous cell or if you're still dealing with an actinic keratosis. So on that grade 3 actinic keratosis, really the only true way to know is a biopsy. And then obviously the higher the grade, the more the keratin. But the problem with keratin is that it obscures your ability to see anything below. So there is no way to know what's underneath that scale. So unless you had something that removed that scale, right, you can't tell. So when there's so much keratin, yes, it can be an actinic keratosis, but if there's so much keratin that you cannot see below that keratin, all bets are off as to what's lying underneath, okay? And again, so once you get to stage 3 actinic keratosis, it becomes quite difficult. Now, in your full thickness atypia squamous cell and invasive squamous cell, what are the hallmarks? These are the features. Glomerular vessels are the most common. In well-differentiated squamous cell carcinomas, you can have white circles. You can have rosettes, the 4 points of light. I'll give you examples of all in a minute. You can have, in the pigmented variant, you can have brown circles, and you can have brown dots aligned in a linear fashion. Okay, so let's go through glomerular vessels. Also known as coiled vessels, and they're tightly coiled vessels. They can be seen in lots of entities, as you can see here. But again, it's context, okay? So, and when you look at studies that report sensitivity and specificity, it all depends on what are you including in your denominator. In your denominator, if it's anything under the sun, okay, then it's going to be a very different positive predictive value than if you're only looking at lesions that are in the differential diagnosis, okay? So yes, psoriasis can do it. Yes, clear cell acanthoma. Yes, in stasis changes on the legs. But in context, they're not in your differential diagnosis for these lesions. So in context, tightly coiled vessels is a strong predictor of squamous cell carcinoma. This is your classic glomerular vessel. This is keratin, okay? So you can't see anything underneath here, and if that was the only thing we had, I wouldn't know what it is because I can't see below the keratin. But at the periphery, I can see glomerular vessels, so these tightly coiled vessels. And here again, example, and you know, when we first saw these, kind of reminded us of the glomerulus of the kidney, and so that's how it got its name. And these are usually found at the periphery and usually found focally. There are exceptions. Sometimes they'll be across the entire lesion, as well, but usually focally and usually at the periphery. So that is your classic peripheral distribution of these glomerular vessels with keratin. That's squamous cell carcinoma. It'll never come back as an AK. That is your classic squamous cell carcinoma. Here's an example of a squamous cell carcinoma where the glomerular vessels are a little more diffuse throughout, but it's still a keratotic lesion. If you ran your hand across it, you would still feel that there's keratin here. So again, glomerular vessels across the entire lesion. They can, on occasion, also give an appearance as if they are aligned somewhat in a linear fashion. If you look at here, they're kind of somewhat in this linear arrangement, right? And that is another kind of distribution of glomerular vessels that's highly suggestive of squamous cell carcinoma. Next structure is white circles. See the white circles here, here. Each one is a white circle, also known as keratin pearls. You'll see the white circle around each one of these kind of pinky areas, right? So those are your keratin pearls, but in the consensus conference, the official term used are white circles. Another example of white circles. White circles is a feature seen in well-differentiated squamous cell carcinomas. They can be seen in keratoacanthoma, but they can also be in bona fide squamous cell carcinoma, well-differentiated type. Another example of squamous cell carcinoma with white circles. And this is the publication. So this was a group of GPs in Australia that actually made this observation. And these are the images of the two squamous cell, and you can see these perfect white circles on well-differentiated squamous cell carcinomas. Okay. Now, the other feature that is common in squamous cell carcinomas, however, can also be seen in actinic keratoses, is something called the rosette. And the rosette is a very, very small structure. So there are lots of rosettes in this lesion here. This is the same lesion. This is with standard light dermoscopy. This is polarized light. Rosettes can only be seen with polarized. Now I'm going to blow this up. And those are the rosettes. These tiny little 4 points of light that are distributed here. And rosettes indicates an actinic tumor or severely actinic damaged skin. And what it represents is actually keratin that it's filling the osteal openings, okay? So here, again, notice all the rosettes throughout this lesion in squamous cell carcinoma in situ. And schematically, what a rosette is basically keratin that's filling the ostia. So keratin filling the ostia, and it's polarized light hitting the keratin, and it's interacting with the keratin and is being transmitted back as these 4 points of light. So another example of a lesion on the scalp here, and under standard light you can see these whitish circles, but under polarized light you see the rosettes. Okay, squamous cell carcinoma with rosettes. You can also see vessels in the background here. This pattern has also been described in the literature as the strawberry pattern. It's a kind of reminiscent of what a strawberry looks like. Now, the next part of squamous cell carcinoma is, the way I describe it is kind of just recognition to boost your ego. Okay, now what do I mean by that? When you look at a pigmented squamous cell carcinoma, and by the way, I have never seen a invasive squamous cell carcinoma was pigmented, so it's really Bowen's disease, yeah? And in pigmented Bowen's disease, when you look at it, your instant reaction is, it's a melanoma. That's your gestalt. You look at it dermoscopically, you said, that's a melanoma. And then if you pay attention, there are clues that this is a squamous cell that's trying to trick you. Now, why do I say that it plays on your ego? Because you see, the management is not going to change for these. Because in every case, you're going to be, let's say, melanoma. You're going to biopsy it. Okay, then you'll come, oh my God, it was a pigmented squame, right? But the management is that you still made the diagnosis, right? The ego part is, if you could recognize it, you say, aha, I wasn't fooled, right? That's kind of the game that you play. So in this case, initial thought, irregular pigmented lesions, it's a melanoma, but there are a few clues. Number one, you can't appreciate it on this, but it has a texture to it, you see. So when you ran your hand across it, it's keratotic, so you know it's a keratinizing process. But on dermoscopy, notice these brown dots that are aligned kind of in a linear fashion. You see these brown dots at the periphery aligned in a linear fashion. That is the clue to pigmented squamous cell carcinoma. And brown dots aligned in a linear fashion. Another lesion. You look at it, and instantaneously you know this is bad. And your first thought is going to be, that's melanoma. And you're going to biopsy it with that, totally fine. But if you look at it closely, notice these dots again, brown dots, kind of in a linear fashion here, okay? And you say, aha, that's probably not a melanoma, that's probably a pigmented squamous cell carcinoma, okay? So that's the feature. And yet another squamous cell carcinoma with these little brown dots that have somewhat of a linear arrangement in them. And remember also, and I kind of highlight that by showing you the clinical here. I'm not sure if in the clinical here, that they do have some roughness to them on palpation, as opposed to melanoma, which will not have a rough texture, it'll have a smooth texture. So the feel of the lesion is also important in the process. But again, a little clue to figuring out pigmented squame. Another feature that can be seen in some pigmented squames or pigmented Bowen's disease are these tiny little brown circles that you can see here on the top of this squamous cell, and these little brown circles up here. Another feature of pigmented Bowen's disease, and another example of pigmented Bowen's disease with these little brown circles. Okay, in any keratinizing tumor, you can have hairpin vessels, and these hairpin vessels usually will have a white halo around them. Now, a hairpin vessel, that's your classic hairpin vessel, but the hairpin vessel can also twist upon itself, and the twisting upon itself is still a hairpin vessel, okay? And so in keratinizing tumors, you can have lots of these twisted vessels. You can see a perfect hairpin, but many times you'll see them twisted upon their axis, but they'll often have a whitish halo. If they do not have a white halo, right, then all bets are off, because melanomas can also have hairpin vessels, but they will have no white halo. So the white halo is actually an important feature in a keratinizing tumor. Now, I'll give you an example. This is clearly a keratoacanthoma. There's no question about this. But it's just to highlight that the hairpin vessels here are here is your perfect hairpin vessel, right? But most of the time, your hairpins are not going to be so perfect. So here's another example. So in terms of vessels, on occasion, you can have dotted vessels in squamous cell carcinoma as well. And here are dotted vessels in squamous cell carcinoma. The reason, I'm going to get back to the hairpin in a minute. The reason that I show this image is to make a very important point, and that is that dotted vessels, okay, when you see them throughout, it can be seen in squame, but it can also be seen in psoriasis. Exactly the same. There is no way you can tell the difference, and hence, to do a cancer screen on somebody that has active psoriasis, right, you kind of have to let the patient know that we're going to do our best, but that your psoriatic plaques or your guttate psoriatic plaques can look identical to squamous cell. And in fact, while I don't say that to patients, they can sometimes look identical to amelanotic melanoma. We'll talk about that a little bit later. So, you know, it becomes very difficult to do a true cancer screening in somebody with active psoriasis. And so be aware. The features of squamous cell carcinoma, remember keratin, always feel the lesion. You're going to feel that it's a rough textured lesion. And in addition to that, you will see white circles. You may see white circles, rosettes, glomerular vessels, hairpin vessels with a white halo. Don't worry, I'm going to get back to those in a bit. And then your brown dots aligned in a linear fashion seen in your pigmented variant. Okay, what about if it's not a basal cell and it's not a squame, meaning you have ruled those out? And remember, this is occurring within seconds, right? I mean, you're not, this whole process takes less than a second to do. Now is your seborrheic keratosis. Now, it's important to say, why did we put seborrheic keratosis as number 5? Because we don't want, what we have learned is many people will see comedo-like openings and Milia cysts and anchor their diagnosis on that as a seborrheic keratosis, ignoring everything else that's present in the lesion, right? And so missing the fact that it may have been a collision tumor with a basal cell, or it's a basal cell that just happened to have a Milia cyst or something like that, right? So we wanted to make sure that the cancers were ruled out before you look at seborrheic keratosis, right? But again, it's just to make sure that you don't anchor your diagnosis on the wrong structure. And so in seborrheic keratosis, what are the features? Milia cysts, comedo-like openings, gyri, sulci, fingerprint-like structures, moth-eaten borders, and hairpin vessels. Again, that's where we'll get back to the white halo. Okay, so those are the features of seborrheic keratosis. Those are the only features of a seborrheic keratosis. So if I see a seborrheic keratosis with these features and I see something else, like an ovoid nest or regression structures, whatever, shiny white blotches in the strand, I mean, it doesn't matter. It all of a sudden is not a seborrheic keratosis, or you cannot be sure it's a seborrheic keratosis and it requires a biopsy. So a seborrheic keratosis is only when these features and only these features are present in all 4 quadrants of the lesion. Okay, Milia cyst and comedo-like openings, for this audience, we're not going to go through the definition. Suffice to say that they are easily visible even to your naked eye, especially on side lighting. Here are your Milia cysts, here are your comedo-like openings, and if you want to see them histologically, they're your intraepidermal inclusion cysts, and then those cysts eventually will get extruded out to the environment, and they'll open up to the top and become a comedo-like opening, right? So that's your Milia cyst and comedo-like openings. So in this lesion, that is not a nevus. We have ruled out a nevus, and it's not a basal cell, and it's not a squamous cell. In this lesion, the presence of all of these Milia cysts and all of these large comedo-like openings makes the diagnosis of a seborrheic keratosis. Okay? Now, Milia cyst is a structure that is more conspicuous under non-polarized light than it is under polarized light. Thus, when you screen with polarized light, you may overcall some seborrheic keratoses as concerning because you won't be able to see the Milia cyst. And so I'm not sure if the video is going to work, but Steve or Dave, if you could just hit the bottom. So I'm toggling between polarized light and non-polarized light, and you can see the Milia cyst will only be present in non-polarized. There. And so without seeing it with non-polarized light, it's actually very difficult to know exactly what this lesion is, okay? Because the Milia cysts are not visible in the polarized mode. So only the non-polarized mode allows you to know that what you're dealing with is seborrheic keratosis. Okay, now seborrheic keratoses obviously also have this undulation, which we call gyri and sulci. And here is a pet peeve of mine, and I'll kind of talk a little bit about the consensus conference. So a couple of years ago, all the dermoscopy experts got together. We had a consensus conference on terminology. And despite my strong argument against, the official terminology is fissures and ridges, okay? The reason I don't like fissures is because in my mind, and I can't get rid of it, a fissure is a cut in the skin. I have a fissure that hurts, right? That's for me a fissure. But in fact, these are gyri, right? These are sulci and gyri, right? Yeah. Nobody bought it, so official language there, but in my talks, I'm going to always talk about gyri and sulci. Now, these gyri and sulci, when they're very early in their formation, they actually have an appearance that looks like fingerprint-like structures. As they become more prominent, they take on the appearance that looks like a cerebriform pattern or a coral-like pattern under dermoscopy. This is your classic full-blown gyri sulci creating a cerebriform pattern. And another example of the same. So these are the gyri and the darker area, the sulci. And why are they dark? Because they're filled with keratin. Okay? Now, in the very early form, right, these gyri and sulci take on this feature that is reminiscent of these fingerprint-like structures. And here's an example of a very, very early seborrheic keratosis. And you can see that these lines, they don't truly form a network. And at the time that was first described, kind of said, okay, it looks like a fingerprint. Here's another example. Notice that the lines are not connected into a true network. And that's your fingerprint-like structure. These are the very early gyri of a seborrheic keratosis that is getting more raised and large. Now, here I want to point out another very important point, and that is to make you remember each time that you take your dermatoscope and you put the dermatoscope on the skin, that while you're getting a lot of information, there's also information that is being taken away. And that it is still important for you to look at the lesion with your eye before you put the dermatoscope on, because you now will convert a three-dimensional object into a 2D object. Okay, so you just have a two-dimensional view of the lesion without any appreciation of the texture, of if it's raised, or anything about that third dimension. So here are two lesions that on just 2D dermoscopy are extremely difficult to know what they are. But I can tell you that if you were to look at those with your naked eye, you would know instantaneously what they are. And sometimes you do need to take it off, but there's a little trick to kind of bring the message home. So I can do something called the ink test. Now, you know, the surgical marking pen that we use in our clinics, right? That's gentian violet, right? You can paint the lesion with gentian violet. And then you can wipe off the excess gentian violet, okay? Where will the gentian violet stick? It'll stick in the sulci, and they will stick in comedo-like openings. So if I do that on these, all of a sudden you can see the cerebriform pattern, and you can see all of these comedo-like openings in a lesion, in both lesions, which are seborrheic keratosis, but you know that they're seborrheic keratosis based on your clinical eye, right? And dermoscopy, by converting it in 2 dimensions, you lose that feature, that third dimension. So the only features here are comedo-like openings, gyri, and sulci that kind of disappear on dermoscopy, right? So you can bring that out in the third dimension by putting on the gentian violet ink. Another place that this is very useful is in porokeratosis. Sometimes you'll have a lesion, you're not quite sure, is this a poro, is this a squame? And by doing that, you can very nicely highlight the cornoid lamella with the gentian violet stain. Okay, and now we come back to hairpin vessels, and I said any keratinizing tumor, so both malignant, squame, and benign seborrheic keratosis can have hairpin vessels with a white halo. So, and here is an example of an irritated seborrheic keratosis, and I'll kind of zoom in on the vessels, and notice all of the hairpin vessels here. And notice that the hairpin vessels, many of them are twisted upon their own axis, right? So twisted vessels, but all of them with this whitish halo. Yeah? That is the hallmark of a keratinizing tumor. Whether it's benign or malignant, that depends on other features that are present. And because of that, when you get an irritated seborrheic keratosis, I will often biopsy them, not only to give the patient relief, but also to make sure that I'm not missing a squamous cell carcinoma, right? So the hairpin vessels cannot differentiate between a squame and a seborrheic keratosis. You need other features present to be able to do that. So in this lesion, okay, if there was something else that I could see, multiple comedo-like openings, Milia cysts, gyri, sulci, something to tell me that this is indeed a seborrheic keratosis, I have nothing except hairpin vessels. For me, I have to biopsy this. This happens to be an irritated seborrheic keratosis, but again, to make the point, right? Okay, in the very early form, so when you have a lentigo that is on its evolutionary path towards a seborrheic keratosis, then these moth-eaten borders is the hallmark. So you get this fingerprint-like, but then you get this moth-eaten pattern at the periphery in a solar lentigo. Another solar lentigo, more fingerprinting in the middle, but classic moth-eaten borders all around solar lentigo on its evolutionary path to a seborrheic keratosis. There is one feature that is worth knowing because it's kind of, when you see it, you'll know it. It's not been described in any paper, but it's described in multiple textbooks. And just by clinical experience, it's valid. And it's something called the jelly sign. And if you see the jelly sign, that's a solar lentigo. And so here's a lesion on the arm. Not quite sure, could this be lentigo maligna, or is this just a lentigo? It does have sort of sharp demarcation, maybe some moth-eaten borders. But in addition, if you look within the lesion, and I'm going to zoom in here, notice these little U-shaped brown structures. And all of the U-shaped brown structures are all going in the same direction. The U is all directed on the same way. And the first people who described this said, like, imagine that you put some jelly on bread, and then you took a knife and you went across the bread, all in one direction, yeah? That you would get this kind of this spread-like appearance, that they call the jelly sign. Another example here of that jelly sign. When you see that, that's a solar lentigo. End of story, okay? We have never seen that in anything other than a solar lentigo. So jelly sign, solar lentigo. Okay, a point about seborrheic keratosis. So I was sort of at the infancy of dermoscopy when it came into the States. And so much of our work initially was to help differentiate seborrheic keratosis from melanoma. But we, very early on, within the first couple of years of dermoscopy, we actually became very good at diagnosing seborrheic keratosis. But there is a problem with seborrheic keratosis, and that is that it's a very common tumor. And while most of them can be easily recognized, there is a subgroup that remain problematic, okay? And they are problematic because they have overlapping features. They may not have the features that we have described in a seborrheic keratosis. It may be a different variant, like a melanoacanthoma or a clonal seborrheic keratosis, different types of seborrheic keratosis that that are not easily recognized on dermoscopy and cannot be recognized on dermoscopy. And those end up being biopsied. So here's an example of a lesion that has features that you just don't really know, right? I mean, there's some features here that could be consistent with seborrheic keratosis, some features that look more like globules and bluish globules. And so in such lesions, you have to biopsy. And it's very interesting, and basically this is just to highlight that dermoscopy has its limitations. But what's very interesting about seborrheic keratosis is that we did a study many years ago where we took multiple centers across the world, and we said, participate in the study, and we want to see every single lesion that you removed, what the diagnosis was, okay, for people who use dermoscopy. And you saw over the course of 10 years, so yeah, what the trends were. For every high-risk clinic, the trend, the number of melanomas being diagnosed over 10 years is going up. The number of nevi being removed is going down. And what's happening to seborrheic keratosis? It's a flat line. Which means that everything that we wanted to know or could have learned about seborrheic keratosis was already learned way back then, and nothing new has come. And those other lesions are being biopsied today as they were being biopsied 10 years ago and 15 years ago, because we have nothing else. It's the end of the road, and the only thing would be now some other tool, whether it's confocal microscopy, OCT, whatever you can think. But dermoscopy, that's the end of the road. Now, I'll give you an example of a lesion where the resident goes in and takes a look at the lesion and says, oh, it's a seborrheic keratosis, right? Clinically, it's a seborrheic keratosis. It has a very large comedo opening. And on dermoscopy, there are 3 Milia cysts and a comedo-like opening. The resident hangs the hat on those structures as the diagnosis. But what else is present here? There are structures here that have nothing to do with seborrheic keratosis. These are regression structures. We'll talk about those in a moment. So they're regression structures. And what about here? They're dotted vessels. Dotted vessels is not a vessel of seb. What is? Hairpin. These are not hairpin. You got dotted vessels, you got regression structures, and yes, there are 3 million a comedo, but I cannot know for sure. This would be a lesion I would biopsy, right? In this case, to no surprise, it came back as a collision between a seborrheic keratosis and a melanoma, okay? So again, you cannot anchor your diagnosis on any specific structure. You have to look at all 4 quadrants, and all 4 quadrants have to have the structures that are consistent with the diagnosis that you're making, and that is the point of this lesion here, that when you make the 4 quadrants, yes, this quadrant is consistent with a seborrheic keratosis, but this quadrant is not consistent with a seborrheic keratosis at all, and so it would require a biopsy. Okay, so the features of seborrheic keratosis in the very early form: well-demarcated borders, moth-eaten borders, fingerprint-like structures, and then as it evolves, you get gyri and sulci, comedo-like openings, Milia cysts. You can have hairpin vessels with a white halo, especially in the irritated form with all the features already discussed. Okay, if not a seborrheic keratosis, now you have a group of lesions that are actually quite easy, okay? You have the angiomas, okay, and angiomas basically consists of lacunae, and you have your sebaceous hyperplasia, and you have your clear cell acanthoma. So let's talk a little bit about those. So in all vascular, whether it's an angioma or a hemangioma, the feature are lacunae. The lacunae can be of different colors, and if they become thrombosed, then they will have a black color to them. They can be red, maroon, blue, black in color, and here is your classic angioma. And a couple of things about angiomas, and obviously you guys know all of this, that each one of these red structures is one big dilated vessel, yeah? So this is a vessel, and another vessel, and another vessel, they're all dilated. And so in between the vessels, there's stroma. And so the stroma will appear as these kind of bluish, whitish lines. You see them? They're kind of going through. So you know that these are vessels that are being kind of pushing the stroma apart. And the histology of an angioma. Now, why make this distinction or this important about this stroma? So that's an angioma when you know that they're discrete dilated vessels. But if you start to get these structures that are reddish, but you can't actually know whether they're truly an isolated large vessel with intervening stroma, they're actually not called lacunae. They're called milky red globules. And milky red globules is a feature of nodular melanoma. Okay, that's an angioma, that's a nodular melanoma. Do you see how they differ? They still have the red structure, but in one you can see the beautiful vessel and the stroma, one from the other. In the other one, it's this mess that is kind of intertwining, but there's no distinction of one versus the other. And it's hard to show on this image, but if you look very closely within the red area, they're actually tiny vessels inside of it. So in an angioma, you're not going to have a vessel inside a vessel, right? The vessel is the structure. So in these, you will often see tiny, tiny little vessels as well. That's another clue, okay? But the main clue is that you actually don't see this distinct stroma separating each of those lacunae one from the other. Now, if a vessel becomes thrombosed, it gets black color. the blackest of black, and this is your thrombosed angioma. And an angiokeratoma will have a play of both black and maroon vessels with a little bit of erythema, and the central area will have a little bit of a bluish haze, and these are schematics of angiokeratomas, but this is your angiokeratoma. So your black lacunae, your maroon lacunae, a little bit of redness at the periphery, and the central area that has this little tinge of bluish, whitish haze. That's an angiokeratoma. These were lesions that were always biopsied in the past to rule out melanoma. We don't do anything with these anymore. That's an angiokeratoma, end of story, benign. Okay, so the features of vascular lesions is basically the lacunae. Stretch this a little further, right? If you actually had no blood in the lacunae, you would still see the spaces, intervening stroma, each discrete space. And what is that? It's a lymphangioma, yeah? So for example, lymphangioma circumscriptum, right? That would look like this. If you had a lymphangioma after, say, somebody that had their lymph nodes removed and had some edema and so forth, so on, they can get these little papules that sometimes the oncologist will get nervous that it's recurrence of breast cancer, right? Well, most of the time it's not recurrence of breast cancer, but it's actually a lymphangioma, okay? And they'll have that pattern. Sebaceous hyperplasia, why bring this in? Because on some occasions, the sebaceous hyperplasia can resemble a basal cell carcinoma, but what they have are these whitish to yellowish structures. Some people call them popcorn-like structures. And then there are vessels at the periphery of the lesion that radiate towards the center but do not cross the midline. So in this lesion here, it's a little bit big, maybe a little rolled border, could be a basal cell, but under dermoscopy, this is not a basal cell. It has these yellowish structures and then these vessels that are at the periphery creating a crown, radiating towards the center but not crossing the midline. The only other entity that has a similar morphology is molluscum contagiosum, okay, and that's molluscum with the crown vessels. And then the last lesion that we'll cover in step 1 of this algorithm is known as the clear cell acanthoma. This is a lesion that, again, in pre-dermoscopy was biopsied with a rule-out basal cell carcinoma or squamous cell carcinoma. And it was dermoscopy that actually allowed us to diagnose these correctly as benign clear cell acanthomas. And this lesion here has a special place for me. So this has now been shown for about 18 years. And the reason is that when I first came to Memorial Sloan Kettering, the pathologists there were not believers in dermoscopy or didn't put any value on dermoscopy. So when we had our conferences, I would say, well, dermoscopy shows this and this, and they wouldn't engage me at all, zero, right? And it was actually after the 5th or 6th prospectively diagnosed clear cell acanthoma, and it happened to be this one, where the pathologist called me and said, I want to know how are you making the diagnosis of clear cell acanthoma, because I would write just clear cell acanthoma without a differential. And so I said dermoscopy. And for whatever reason, that was the lesion that allowed the pathologist to connect with me, and for the last 18 years we've collaborated, right? And they put value on what we as dermoscopists are seeing. But it was this silly little lesion that actually broke the ice, right? So clear cell acanthoma. And what is the pattern? It's vessels that are distributed in this string of pearls-like pattern, right? And that is the second feature that has 100% diagnostic accuracy. There is nothing else that has this pattern with vessels distributed in the string of pearls. So this is your feature, pink lesion, a little collaretta scale. Look at it dermoscopically. There's the vessels in this string of pearls. Some people call it chicken wire-like pattern of a clear cell acanthoma. We no longer biopsy these anymore. This is a clear cell acanthoma, end of story. And that's the pathology of a clear cell acanthoma. Okay, so that is step one of the two-step algorithm. So that's the card that you have in front of you. And with that, we'll go to the second talk, which is going to be step two, right, of this algorithm.